to the presentations. What's the plan for this?
Are you guys ready? Good. So we're going to laugh about some presentations and we're going to upload to others. And who wins the best, he gets the reward. Serious. Well, we have... No. It's going to be a little bit more appropriate, let's put it that way. Is that my friend Joachim? Okay. So this is how it works. We didn't assign who's going to go first, but we have some volunteers. I think, Sarosh, you wanted to go first, right? Where is she? Okay.
But first.
Here's the rule. And we have to be very strict because of the time restrictions. Some people are traveling tonight, okay? You're not traveling. You're attending another course, huh? Okay. So the idea is, okay, Ukraine is going to go first. But if you don't stay till the end, you will not be able to vote. And we have a voting ballot, right? You will vote democratically. Today is a Tuesday. We are voting today, November 6th, right? And so you're going to vote. We will count the votes. Right? It's very important who counts the votes. And who has the biggest number of votes, he wins. Right? So, Sarosh, you... Okay, who wants to be the first? Ukraine? This is their presentation up already. Ukraine, look, total time is 7 minutes. You have 4 minutes to present your 38 slides. Just kidding. No, just kidding. And there will be a couple of questions and answers, and we'll be very strict with time. Okay? We're done. Ready? You can do it from here, you can do it from here. And here's the clicker. Next.
Давай ты будешь микрофон, а я здесь. Ты будешь ходить, или наоборот.
Okay.
Clicker.
Here's the clicker.
We'll press
Next.
here and there.
Next.
I wish you could just give us one option, and I don't have to decide.
Which option do you want?
Mic or this.
Okay, you take the mic.
Okay. And the click? How do you...
That's what I'm trying to explain. Yes, here's forward, here's back.
Thank you.
Good. So we already spent 2 minutes.
Okay, hello everybody again. Our story is about reforming emergency care in Ukraine. Two of us will be presenting the story, but the 4 of us worked on this presentation. Today here, myself representing Single Payer, National Health Service of Ukraine, Ministry of Health, World Bank, and Ministry of Finance. So I'll try to do everything quickly. So this is just to put you a little bit in the context what Ukraine is like. Important things. We are low-income country. It's not PPP adjusted. Okay, low-medium. We have huge share of shadow economy. The next year is the year of presidential election and parliamentary elections. And another important thing, in 2014, Ukraine suffered annexation, which influenced a lot our GDP and also resulted in increased number of injuries. This is this is the snapshot of our healthcare system. We have big portion of out-of-pocket payments. It's out of open-ended, unlimited benefit package, which actually does not work and never worked. We have underutilized and poorly equipped provider system, and our primary care performed really poorly. Ukraine, at the break of last year, beginning of this year, adopted a healthcare financing bill, and we embarked on the healthcare financing reform. This year, we aspire to finalize contracting of primary healthcare provider, of which we have approximately 1,000. And next year we're doing piloting in inpatient and outpatient care. And starting 2020, we will roll out across Ukraine with a guaranteed benefit package.
And our presentation is mostly about the emergency healthcare because we kind of finalized our primary healthcare reform plans and we know what we're going to do on the hospital level, but we never thought about the emergency care. So we tried to think about how can it be and how can it look like. So to the most, in terms of our mortality rates, the highest amount we have from the cardiovascular disease and also from trauma. Cancer is on the third place. And that's basically those type of deaths that are avoidable. Because a lot of times, even if the ambulance arrives at the point where the person is, they cannot save him. They don't know what to do. Even if they know what to do, they're taken to the hospital where they don't have any angiography and then they cannot put the stent. So kind of a lot of deaths that we could have avoided, but we didn't. So we went through the diagnostic trees in all three perspectives, so access, quality, and efficiency, and we have identified the major problems we have, which is about the long waiting time for the patients, poorly organized system, low quality in the system we have, and lack of equipment.
Yeah, our suggestion or ideas as to how to increase financing was to simply draw on third party or not related to healthcare directly or Ministry of Finance resources. For example, persuade the Ministry of Infrastructure to improve road financing and improve the quality of the roads, or agree with the private sector to arrange, to impose requirements on private sector and also municipalities to make available first aid kit at the places where people gather. Can you the next one? EMRs. And also train EMRs. Thank you. How we're going to the payment methods changes that we want to introduce. Currently, the whole system is financed with a line-up budget, and for ambulance, we propose to include it into general benefit, into guaranteed benefit package, and pay under global budget, but incentivize performance-based results, but pay on performance-based incentives. For emergency room, we also suggest that we include it into guaranteed benefit package, but pay under DRG as for inpatient care. The reason for that is we strive to improve the efficiency. It discourages patients' retention.
And we have also looked about the organizational changes we need to make. We have to establish emergency care agency, which will be setting up the national standards. We're going to introduce some new educational facilities for our emergency care staff, because we don't have now no paramedics, EMRs, EMTs. This is something new we need to have. We don't want to finance public education, medical education facilities. We want to outsource this to the private market, and we also want to establish integrated dispatch system, because as of now we have really fragmented dispatch system. If the village, for example, is on the border of the region and there is a close ambulance close to this region, but from another one, they will not get to that patient. So we need to centralize these things. We looked at stakeholders, so basically three major ones we need to work with. Okay, our President, Ministry of Finance, and our labor organizations, because they are the most powerful, and we know how to catch them up in terms of politics and other things. And we also work on some behavioral changes. So we thought about some changes both in this for the system and also for the patients as for the users of the system. For example, for the patients, as one of the main causes to call the ambulance are driving accidents, so road accidents. So we thought about sending drivers cards together with the bills when they are overspeeding or when they're like not compliant with the rules, to send them a card and encourage them to become the donor for like organ donors, because anyway in the next days they can become organ donor. And also we want to encourage the system to work in a team, so we want our general practitioners receive only like 90% of the payment, and the rest 10% they will achieve only if their chronic ill patients will not call ambulance, so will not have heart attacks and call ambulance, as well as the 4 emergency teams. So they're gonna also have bonuses just as a team, not on the different lines of the, so not separately for ambulance or hospital, only all together.
Questions? All right, let me summarize a few things.
How will you measure progress?
And then performance.
Did we have this in our tasks? So we will improvise.
Okay, several things. It's always useful to give a background of the country, but it really eats the time. So what I suggest for next presenters, go with your problem that you're trying to solve. Explain why emergency care is important. Is 300,000 deaths too much or too little? How is it compared to? So we have a problem. Okay. So we have a problem with people drinking and driving. Therefore, it is causing too many things.
And we also want, this is like at the beginning of the reform, and we really need to make it visible in order to go on with it. So this is like a visibility, manipulation, yeah.
Remember what happened in Turkey? They did a very good job on that, right? On control command center. So you want services to be accessible in order to achieve your objective, but you also want to reorganize how the system of delivery is done. And what you're trying to do is to organize this centrifugal system where you send paramedic to bring the patient in instead of sending a team with doctor and nurse. That's a huge change. And there will be opponents and there will be proponents and stuff like that. Then you want to centralize the system to make it more efficient, right? You want to incentivize payment for performance, which I always wondered, how do we measure performance in emergency medicine? I mean, if your patient dies after the car accident.
Well, it's most of our heart attacks, because the bigger
Heart
amount
attacks.
of patients who have are heart attacks. So if they are in this like
Okay.
golden hour, if they are able to reach the patient, to bring them to the hospital and to perform the necessary.
Okay, there are very specific indicators for emergency medicine. I happen to be doing that. I was emergency medicine physician in my previous life. So it's how much time takes you from receiving a call to get to the patient. That's more important. And then whether you protocol and stuff. Okay, interesting that you have all control knobs practically covered. Regulation, you want to impose the sending cards to people? Is that card linked with a dollar payment if they speed? Or is it to remind them that they may become an organ donor?
Yes, it's to scare them.
Dear Nadim, you were driving 15 miles over speed limits, and remember, you may become an organ donor tomorrow. Hint? There's a very interesting slogan here in the United States for changing drivers' behavior. Friends, don't let friends drink and drive, right? Very powerful. What happened is that you change the social dynamic in the group, and you have a designated driver in the group. So everybody drinks except one. And that one feels really good because he's responsible for his friends. And that has reduced number of car accidents among you significantly. Applause. So this was Group 1, Emergency Medicine, Ukraine. Group 2, Lebanon. What is the problem you selected? Lack of financial protection.
For outpatient care. Hi guys, so we're the Lebanon group. We have a lot of World Bank on the table and USAID, so we convinced them to work on Lebanon. Okay, thanks, great. I will be very, very, very quick. Our slides are very comprehensive, so if you have any questions, I can answer that. But I don't want to go a lot into details because we have limited time. Okay, so very quickly, Lebanon is a middle-income country, high middle-income country. We have 4 million people, 2 million refugees, okay? Our health system is very curative-based. Public financing for health is low, keeps decreasing. Most of our public financing for health goes to curative care, inpatient care, expensive care. Only 5% goes to primary care. Out of pocket is 37%, most of which is spent by people on outpatient care. This is what I need you to know. So, who covers the Lebanese? We have a lot of schemes, but the most important scheme covering almost half of the population is the Ministry of Public Health, which is actually a non-contributory scheme that covers the uninsured, okay? And they cover most of the people for the inpatient care. What do we cover? So we are the AMO-PH is an insurer of last resort, and this is what I want to focus on in our problem and in our solution, because we cover like 50% of the population. So what do we cover in our AMO-PH scheme? A lot of inpatient care, very comprehensive package. Outpatient care is focused on tertiary care, expensive, low-frequency stuff, kidney dialysis, chemotherapy. This is what we cover in outpatient care. And we cover drugs. Not very well, but we do cover drugs, and we have caps on drugs in pharmacies. Now, this leaves the gap of the outpatient care. So anything primary care is not covered, anything from the preventive care is not covered, which means that you have a lot of foregone care. People do not go to care because they cannot afford it. Okay? You have a lot of unnecessary hospital admissions. So since we don't cover it outside the hospital, they get themselves admitted and get covered inside the hospital, which makes it expensive. And so if, at the end, we have catastrophic health expenditure. So if you need an MRI, for example, it costs $500. You only get $500 per month as a, average Lebanese. So this brings us to our problem. So our problem is lack of financial risk protection of Lebanese poor for outpatient care. So we're focusing on financial risk protection, we're focusing on the poor, and we're focusing on outpatient care. We did a very thorough diagnostic tree. I will not go through it. I want you to just focus on the things that we felt. So we picked, the team and us, we picked 2 main ideas that we can work on that we felt we can influence most out of all the problems we diagnosed in our tree. We picked first that the public insurance schemes, including the AMO-PH scheme, do not focus at all on outpatient care, which comes back, why does this happen? Because number one, we prioritize inpatient care because the hospitals are very politically powerful. They have syndicates, they push for inpatient care. And 2, because the public demands inpatient care, they demand expensive care. They do not demand inexpensive outpatient care. And we also have the outpatient care that is actually supposed to be affordable by the government given through primary care, and people do not utilize it as often as they should, mainly because they do not know about it. So this brings me to the areas of concern. Like I said, low prioritization of outpatient care and coverage, and number 2, lack of awareness of people at the public level, affecting 2 things. Their demand for outpatient care, because we need people to demand outpatient care to get it into the reform process, and 2, their utilization of affordable outpatient care. So they go to the private outlets instead of going to the primary care outlets. So what are our planned interventions? We're going to expand the AMO-PH non-contributory model to cover outpatient care, and we're going to implement demand-side interventions to actually raise awareness so people demand this kind of care. To do that, we need to revise our basic benefit package, because right now we have a fragmented implicit benefit package. It is not a comprehensive, harmonized one that's explicit. That's what we need to do. We need to find out what is the cost of the package, what are the things that we're going to need to exclude, and how can we cover this. So, to go into the knobs, how will we finance it? We do not think that in Lebanon it's feasible to get more money into health. But what we think we can do is that our current spending, the way we're spending, is inefficient. The way the Ministry of Health spends on expensive care is inefficient. So we think the costing exercise will show that if we get some money from the inpatient care budget, put it into outpatient care, it will be enough. Okay, so we decrease the inpatient care budget and increase the outpatient care, so reallocation. In terms of the payment knob, we're gonna go, just like we are currently with the inpatient care, we'll still pay for the hospitals the same way, we're not gonna stop covering, but we wanna enforce the ceilings. We already have ceilings in our contracts, but we want to make it even more enforced. So till now, usually the Ministry of Health, when a hospital exceeds the ceiling, we bail them out, we pay. But we want to stop that, we want to enforce the ceiling. And in terms of outpatient care, with the primary care centers, we currently have active contracts with primary care centers that we can capitalize on. What we can do is make it a capitated fee, something similar to the Thailand model, where they have empanelment of people, they get a per capita performance indicators within this kind of scheme. Okay, so I'll just go quickly. Nothing else. Okay. So we did some political analysis, and we think the hospitals might oppose that because we're gonna reallocate money from inpatient to outpatient. So we thought what we can do is we can tell them that this money is still gonna go to you. And right now in the Lebanese system, they experience a lot of delays with the hospitals because we don't have enough money because they keep exceeding the ceilings. So we'll tell them, when you don't exceed your ceiling, we will actually have funds to pay you on time. So we don't pay you 5 years later, we pay you now. So we hope that will work. And I just want to say about persuasion that we will work on empowering citizen with an explicit package, empowering citizen with knowledge, and trying to build up demand for this kind of package. And thank you. I'm sorry, I think over everything. 7 minutes is not fair. Any questions? Super.
That's a skill.
Yeah.
Michael?
Do you have enough primary health care facilities to actually serve?
Yes, we do. We've been building a network of primary care centers for the past 20 years, and we currently have 226 primary healthcare centers that are part of that network, which are supposed to be able to do that. Yes. Okay, so we already have, quality of care, we've been working on it at the primary care level and at the hospital level. We have accreditation programs at both levels. We have monitoring, so it's institutionalized. Our only problem is really financial risk protection, covering this care.
Thank you so much. Who is next? Sure, go ahead.
You said that you're going to relocate the budget from IPT to OPT.
Yes.
So how are you going to convince the finance or the government, because IPT is like high-end cost and OPT is less cost for a beneficiary for once. So how are you going to work on that?
Okay, so the fact that we don't want to bring in more money is because we were worried because they will not accept bringing in more money. This is why we thought of reallocation. So we'll say, okay, you want to give us $1 million of budget? Let's arrange it this way, not that way. That's number one. Number two, we can say that in the long term, this will bring in cost savings for the government, because once we do the costing, it will show that we're paying a lot of money that we shouldn't be paying when we're with the hospital readmissions and people going at the end of the spectrum instead of catching them in the beginning of the spectrum.
Let me follow up. This is a great point. You know, economists love to say improve efficiency, shift from the inefficient to the more cost-effective. Okay? Moving money out of hospital-based care is going to be difficult. Okay? So you can say that, but you need a plan B. Okay? Because the hospitals will fight tooth and nail to prevent that from.
There's something that I wasn't able to say. Okay.
There's something that I wasn't able to say during the presentation. We have a very good relationship, the hospital, the Ministry of Health, and the primary care sector. Our system is built on public-private partnership, and there's this mutual trust. I know it is not easy, but I believe that we have enough capital with the hospitals to convince them that this is okay, to tell them that they will still be getting money from the government and it will be more efficient and quicker. So right now some hospitals wait 10 years to get their bills settled by the Ministry of Health. If we can bring evidence that shows that they will get their bill settled within 1 year or 2 years, they'll be happy. Because cash now is better than cash in 10 years.
So great idea. This is also a concrete indicator to know whether the plan is working.
Okay, next is, thank you so much, Oya. So, this was group number 2, Lebanon. And now,
Do we have volunteers or do I pick?
India. Good. You want to speak here or you want to speak here?
I'll speak it.
Whatever you want. Where's the clicker? Clicker. Okay. Forward, backward.
Good afternoon, colleagues. The problem we have taken is the high out-of-pocket expenditure. It's out-of-pocket expenditure in households with no children and older people. It has been measured in last 4 surveys by NSSO. It's an organization, statistical department organization in India, which takes detailed indicators. It has risen from 52% to 75%. So 75% of expenditure in out-of-pocket is too high. If we compare it, it showed us that the major number of expenditure is on medicines, from 72 to 68% in rural and urban areas, and there were families not taking medical advice. In rural and urban, it was 57 and 68%. So these will be, if they don't take advice, they will shift from high probability low cost to low probability high cost. They will be, whenever they will go for secondary or tertiary care, and that will be very damaging for them. And they take loans from taking care, that too from 25 to 18%. And one more important thing is many of the families are not covered under insurance, any kind of. There is a epidemiological shift. As our life expectancy is 68.8, it is growing further. So there is a change from CDs to NCDs. As we see, 53.6% was in 1990 the impact of communicable diseases, and now it has reduced to 27.5%. Although road accidents have increased, and the communicable diseases, the NCDs have risen from 37.9% to 61.8%. And if we see in urban areas, there are roughly 82% of families which are not covered with any kind of insurance. And if we see rural areas, there are 86% of families not covered. So it's one of the biggest problems in India. To combat this, we did diagnostic tree. High out-of-pocket expenditure was because of no public facility or no non-effective public delivery systems or more use of private providers. And we further digged up that like non-effective public facility to lack of specialist and trained HR, non-availability of drugs and diagnostics, and no proper care at doorstep. And then again further we digged up to the control knobs like lack of funds. Fund is unavailable for procurement of drugs and diagnostics. As I cite example of my state itself, I need roughly 10 million rupees, $10 million for my drugs for a year. And I roughly get $3 million, 1 million from my state government and 2 million from government of India. So it's always a challenge to have funds for medicines, drugs and diagnostics. To see all these problems, government has come up with a very innovative kind of scheme, that's Ayushman Bharat, in which in the primary care, which is high probability, low cost, roughly 20% of services are in maternal and child health. And and that too, some 80% of services which are focused on NCDs and other chronic diseases have not been covered. So there's a shift that we will be having, converting our health sub-centers into health and wellness centers. In the country, there are 1.5 lakh health and wellness centers to be converted within coming 5 years. And in the secondary and tertiary part, a universal health scheme in all over India, it will be 40% of the population, but in my state it will be 100% universal. Each and every native of the state will get insurance coverage up to the tune of $7,500 per year per family. And there were three type of natives in my state. One was government employees, and another was SECC people which were getting benefit from Government of India scheme, and the rest were remaining 1.3 million families. So we were able to convert the Government of India scheme Ayushman Bharat to Ayushman Uttarakhand, and it was a very tough journey. There were many stakeholders. The ruling political party was very kind to us. Network of private providers, they had some issues. It was mainly off rates. Government employee unions were a bit supportive to us, but finance department was one which was saying that no, it's tough, we will not be able to give you more money. We were able to negotiate with them, and we had opposition party. They said we already have a scheme, why you are going for this scheme? So we were able to get the financial and the institutional arrangements. We passed in government order. We made a state health agency, and we made different persons who will do what, how will they do it. We had infrastructure arrangements till till districts and in the hospitals also. And we are now in the stage of rolling out the scheme and doing IC of the scheme. And thank you. I hope I completed in time.
Questions? Wow, the other just came on time. The timer. Questions? Was this clear?
When you make people focus on the play, so hard for us to formulate questions.
You know, ministers of finance have only little time. You have to be concise and say A, B, C, D. Ooh. Yeah. All right.
How will you pay for this expansion of services?
In the case of Uttarakhand, we calculated, and we had a budget for first year to the tune of 200 crores of rupees. I had 65 crores in my budget provision. We had a provision of contribution from people, and we had 50 crores coming from Government of India. So we were able to motivate the state government that we'll be pooling in resources from different segments. So no extra budget provision this year.
So are you going to ask people to pay a premium?
No, it's only for government employees who will be getting, apart from IPD care, they will be getting OPD care and diagnostics free at cashless.
Why are you not asking people to contribute?
Although there might be some political answers to it. Initially, the government is saying no, but later on, as we grow along the journey, we might think of this.
Do you think people are willing to contribute if they think something is of value?
It will depend upon the usage. If they are able to use the services in a better way and they will think that this is helping them, probably then they might be able to contribute. But that too, we will be doing it in incremental way. We can ask that whoever wants to pay, he will be getting treatment, because there are category of beds in normal hospital. There are general beds, there are semi-deluxe beds, deluxe beds, as it's in the government cases. So we can say that you will get treatment in higher level of beds. That may be one reason people might to contribute.
So this is a, as everyone knows, very ambitious scheme in India that has been rolled out under the name of Modi Care, the Prime Minister, in preparation for the elections next year. And so there are questions about, will this be financially sustainable over the short term and medium term? And can the coverage be connected to actually the capacity to deliver services? So again, I think that this is a very interesting, huge policy experiment now going on in India, and the world will be watching.
Thank you.
Thank you so much. So we discussed Obamacare, we discussed Modi Care, we discussed Octavio Care. There was quite different plans and reforms. Kosovo. Ibrahim, are you presenting Kosovo?
No, he's the main advisor.
Oh, he is a consultant.
Good afternoon, everybody. We will be very short and concrete in our policy tackling about our high out-of-pocket money rate about outpatient drugs in Kosovo that is recently happening. Even that our government established the health agency fund, they are still struggling how to start this fund. And in 2020, there are plans to start to collect the premiums, which it will be 50-50. So householder 3.5 euros and employees it will be 3.5. But still, there's no plans how to start, how to implement this health insurance fund. We start with demographic of Kosovo, with 1.8 million people. It's a very young, the youngest population in Europe. So as you can see, nearly 80% is under 20, it's still 34 years old. This is the slide which will help us to conclude our presentation in the end. So the government, the public sector, the public drugs are supposed to be covered by the government through the public pharmacy, but it failed. Even that there are some supplies of the drugs from the government, but not the essentials. So for the outpatient drugs, for example, for heart hypertension, diabetes, most of the people, they buy in the private pharmacies, including also the pediatric drugs. Will go to the deeper chronic disease that people should get it for free. And based on this data, we went further on how to shift this from the Ministry of Health and Health Insurance and Fund to establish their capacities.
So further on, I will just try to tackle a little bit what actually we did, even though I don't, it is readable or not. The red box actually represents what is our topic. Further on, we expanded on two main cut causes why the reason is happening, and further on, we just decided to go deep on the details. The green box is actually the mean for which what policies we are actually going to develop to increase the out-of-pocket expenditure. Some people might say, okay, this is really huge reform to do, but actually this is a real case, a real issue in our country. So the ministry, the director of the health insurance fund and the director of the main hospitals, they're actually aligned. So the three of them agreed to implement such reform. For example, in developing and buying new procurement drugs, we thought that we should take the budget from the Ministry of Health and provide it to the Health Insurance Fund, and therefore we should take their power because they are more professional in buying, and also in the future they will be the ones who actually will contract everything which is meant to be for the hospitals. For example, we tried when improving compensation benefit packages, we think that in the future the fund will have around 60 million euros. So we need to get very professional people, and we know from our experience, we believe that not many people will come to work there for like a very minimum salary or something as a average salary. Also, one other thing is lack of human capital. So we'd like to hire more people to come professional, also to have more data analytics and health economists. We believe that health management, even though it might sound more like health problems, but in the gene they are more like economical problems. So Kosovo system, as I mentioned before, I will just skip the slides. And the main criteria here is we'd like to take funds from the Ministry of Health and bring it to the Health Insurance Fund, which actually is in the new era of getting established. one other big determinant in our case is also the health information system. We had a project which was with a look development agency, but actually it failed. So everything we have to start it from the beginning, and this is really challenging, especially dealing on the making indicators on to see how to progress and also measure and do any really good policies. Based on the stakeholder analysis, we believe that the main one who actually might challenge us is the Ministry of Finance, because they would say we don't have enough money for this policy, but we believe up to now the government had a infrastructure concern to build the roads and everything. From now on, we believe that a portion of that funds could be reallocated from the infrastructure to give to the out of pocket to drop down the rate, and we believe this is really realistic. The other agencies or other counterpart stakeholders, we believe we are in our side. Especially doing this, we might have only management and technical issues. Persuasion, we believe that for this we need to have a strong political debate which works in our favor, because all the parties, they now seen as a priority of the healthcare. And we believe with the support of donors and NGOs, we believe this is very reachable. So thank you for your time.
It's really quick. On time, specific.
I need just to clarify the demography, the slide that we show the demography, because the intention is when the health insurance and fund starts, we thought to cover the outpatient, this drug, NCD drug for chronic diseases. We have a low number of population for that, and some pediatric drug. This will be relieved as a burden from the householder, because our pensions in our country are very low, so people cannot afford to buy the drugs. So because the householders buy the drugs for their parents and for their children, if we cover these two segments, some pediatric drugs and the pensionist drugs, so outpatient drugs for the chronic disease, this will be a relief for the householders, and they will be happy. In the next year, then we will increase the package of the drugs, and also in the same time, the budget of the health insurance fund will aggregate more funds for the future expenditures of the drug list. Thank you. Sorry.
Also, Mr. You should bear in mind that Kosovo is for the first time establishing health insurance fund. So more or less, we are really new into the health scene.
Yeah, that's right. Actually, Kosovo had social insurance fund, and then it closed for different reasons, and now putting it back together is another challenge, right? It's difficult. So what I understand is because of your demography, you have very young population, and NCDs are actually for elderly pensioners, and if you want to help households, that's where you want to invest in to reduce the cost of drugs for chronic diseases.
And it's also, it makes a bit social impact in the overall of the populations, because I mean, elderly and children are very sensitive aspect, and I mean householders, they should save some money.
In Kosovo, they respect the elderly very much?
Sure. Yes, because they are very small numbers.
But in general, even 20 years ago, I remember that the household was the elderly man that was the head of household, and it was very communitarian society.
Not anymore, because it is poverty.
On the last slide on demography, up to 34 years, the total percentage is coming to 82%, right?
Yeah.
So what is your life expectancy?
70 years old.
So after 34 to 74 is hardly 16% of your population. So, I mean, that's very amazing, actually.
Yeah, it is strange.
Yeah, but it's dropping gradually now. It's not, in 10, 15 years we will have problems with demography, because it's going down.
People are getting married, so they are pushing the marriage up to 30. Before they used to get married 24, 25, they used to have 5, 4 kids. So the trends are changing. Also the level of education to people is gradually going up. For example, back in the time 20, 40 years ago, you cannot find really so many people actually working for international and going to high elite schools. So nowadays, even the women, ladies, they are getting educated.
All I wanted to say was that the population between 34 years and 70 plus
Yeah.
is only 16% as per your data, which sounds, I mean, I don't know, it's very amazing.
I think you got something wrong.
So, I mean, the data, I mean, yeah, that's
But
something.
still, it's one of the youngest populations in Europe. So,
Okay.
thank you very much.
All right. We have to move.
Any volunteers?
So Ukraine was the first one. Second one was Lebanon. India was the third one. Kosovo. And fifth one is
Any volunteers? Kyrgyz.
Kyrgyz. Or Republic.
Okay, this is a presentation of the group work on Kyrgyz Republic. So for those of you who are not familiar with our country, this is the information and map. So this is a small country of 6 million population, which is located or situated among giants like Russia, Kazakhstan, Uzbekistan, and China. So, and you can see the basic demographic data on Kyrgyzstan. So, and if to look at this, it kind of looks comparatively to some other developing countries kind of okay. But if to look into details, into quintiles, then you can see that which problems we have. For example, on infant mortality rate, again, for Central Asian countries, it looks like kind of 15.6, but 50% of them in the bottom 40% of the population, yeah? And same with under 5 mortality rate. So if to look at contraceptive rates and other kind of things look might be not that bad. But again, devil is in details, yeah? Next, 1 second. So, as we will be discussing about like access, efficiency, and quality, so let me start with access. So this is a picture from our country, and 3/4 of the territory is mountainous. So that tells also about access, yeah, to services, especially in rural areas. So this is how Kyrgyzstan looks like, yeah. So when we were discussing problem was identified by MPs who were in our group, and they proposed to work on low satisfaction of population with health sector, particularly with the primary health care, which was kind of surprise to us health professionals in the group. So in the group of the work, we followed methods and concepts which we were taught during this course. So when it comes to access, again, it's just like, if to look at data, everything looks fine, yeah, but if to look at kind of effective access, then there is a problem. Like 2% of population only reported that they don't have access to services, but only 55% of population had a positive opinion about the health sector. And key problem is the quality of care, poor quality of care due to the problem with the knowledge and skills of health workers. For example, like 99% of deliveries is taking place in maternity hospitals, but mothers are dying in the hospitals, yeah? So, and then when it comes to efficiency, so we're still struggling with inappropriate allocation of resources, and we had experience with the non-working institutional incentives and poor management of facilities. Okay. So when it comes to quality of care, so 2 aspects on structural quality of care. We have problems with infrastructure and equipment, with the human resources, like a primary health care is understaffed by 39% and 41% of health workers in rural area of pre-pension age. Yeah? And we have a problem at the PHC level that there is a low detection of non-communicable diseases, and only 4% of hypertensive cases were detected by primary health care providers, and low motivation of staff. And let me give you an example on non-communicable diseases, like diabetes is covered under the benefit package, but benefit package does not include this test, hemoglobin, what is, yeah. So, and 15% of diabetics patients only diagnosed at the primary healthcare level, while 60% at the hospital level. So patients get to the hospital already in coma. In regard to the process of care, problems with adherence to clinical protocols, knowledge and skills of providers, and excessive drugs prescriptions, which, so in regard to efficiency, so we have had the first generation of reforms, and we did quite well on restructuring of the sector, but there are still some excessive capacity, particularly with the small hospitals. And the problem which we have at Health Insurance Fund, which is a single payer, is obliged to contract with all public providers. So it has a limit in, it's like a purchasing ability is limited. And we have a 37% financial gap in financing of benefit package. And existing provider payments have not been revised for some time. So 66% of public spending goes for hospital and only 28% for public primary health care. And capitation payment for primary health care providers was not revised, not adjusted, so no incentives to use it. And we have problems with the benefit package, which is non for poor, like we have 47 exempted categories, and package is implicit. And outpatient drugs are covered only for insured group of population. So, and okay, these are the pictures just like as a significant share of the out-of-pocket payments done by population, which explains why people are dissatisfied. So this shows the same by years, so that you can see. Next one is by quintiles, so that like these are the expenditures for drugs, sorry, out-of-pocket expenditures for drugs, and you can see that like a yellow bar is how much people are spending on drugs. And this is out-of-pocket payments as a percentage of household expenditures, also by quintiles, and you can see it's just like for both, for all categories of patients. So in regard to, financing issues are, now we have discussed about what are we going to do. So we would like to sustain public financing of the sector, which has been at the level of 13% of total government expenditure. We would like to increase excise taxes for alcohol and tobacco, and to expand insurance coverage to cover informal economy, people who are in informal economy. And we envisage that the government will continue to scale up by performance-based financing based on results of the PBF, which we had at the hospital level. Now it's being scaled up using public funds to the entire primary health care and all levels of hospitals, and increase budget for outpatient drug packages. And on organization, to do better on prescriptions and compliance with clinical protocols. And there is a number of activities which need to be done at regulation level, particularly on revision of benefit package, outpatient drug package, and provider payments. And on persuasion, just like at work with others, including MPs, other ministries, and population. And we did mapping, and so this slide shows that like whatever we discussed before also is kind of repetitive here. This is the same, and just the picture. Thank you for your attention.
I really hope you will be able to convince members of the parliament. Where are they?
No, they actually, members of the parliament, at least those who were with us here today, and they had to leave, but they have agreed and promised that we will be having some kind of 2 days type of flagship course, and we have discussed already sometime in May for other MPs, which is kind of good feedback to you.
Very good strategy. If you want members of the parliament to support you, bring them to Washington for a lecture course. That works. That's good strategy. Just kidding. Actually, Kyrgyz is the place that I worked for several years, and the place is just gorgeous. We were at 3,000 meters once supervising, and there was 3,000 meters more to go. So and the Lake Issyk is gorgeous. All right, any questions? Sarah?
Out of pocket as a percentage of household expenditures? So that's also including the premium for, what is the house, other than out of pocket, what is the household expenditure?
As a percentage of total household.
I'm just wondering, are they not the same thing, out of pocket and household expenditure? Okay. I see, okay. Great, okay, thank you. I just didn't see the slide for long enough. Thanks.
Okay. Thank you so much.
Any
Moldova?
volunteers?
We volunteered Moldova before. And after Moldova is Nigeria. Moldova, Nigeria, same. I mean, it's kind of...
Hello everyone. We represent the team from Republic of Moldova. Myself is from the Ministry of Health, Labor and Social Protection, and Mr. Valeriu from the Swiss agency, and Adrian, Naomi, and Volkan. Many thanks for your help. So. A quick introduction about Moldovan's health system. I want to stress that in Moldova we have one pool of mandatory health insurance, and this pool is managed by the company of health insurance, national company of health insurance, and the financing or the financial for it's composed by the payroll tax, by the state transfers, and for the self-insurance flat rate premium. Also, we have one benefit package, and from for the emergency, primary, and inpatient service, you can we don't to pay. They are provided without any charge. Also, I want to mention that now in Republic of Moldova are running three big reforms. Firstly, it's about public health reform, medical care reform, and hospital reform. So, about health problem, we discuss a lot, but you choose to improve health status by addressing inefficiency in health service delivery. Yes, because we are very interested to spend a lot of money, because I want to stress that Moldova stress a lot of money. It's about 10% of GDP, and we want to spend this money better and more efficiently. And there are a lot of inefficiencies which could be improved. And Mr. Valeriu will explain the diagnostic tree about this problem.
So based on what has been described, we identified that the health status could be improved by improving or addressing inefficiency which still exists in Moldova system, and especially related to majority which is covered by health insurance. So we didn't reflect entirely all diagnostic tree. We just picked most important, and we put two lines. One by responding or by answering why, or 5 why. So the low efficiency is because the low finding of cost-effective services still exist in Moldova, and this is why it's still wasting of public money, especially which is allocated mostly for hospital care. And this is happening because we have still a large number of hospital network, and also perception of the population still exists. It's a heritage from Soviet time. They believe much more and trust much more in hospital care instead of primary health care. In the same time, other line we put as a related to the problem that there are still few incentives to address or to access cost-effective services, especially at the primary healthcare level. And the service provision or procurement, it's still not based on performance. It's not performance-based approach, and it's still the problems related to not very big trust of population in primary health care. So respectively, we define several intervention because reforms could not be just separate. It's necessary to have much more holistic approach and to see how we can, using different control knobs. Please, next one. So here we put several control knobs, which is now opinion are more appropriate to address the identified problems. One is organization. By better designing of primary healthcare providers, by regionalization of hospital care. This is also combined with the providers' payment, which mostly is oriented to incentivize the providers, and of course persuasion to make the population to trust in primary health care and to have much more correct or adequate choice by asking primary health care and using this gatekeeper pathway. In talking about intermediate yes, so it's we look how to by improving access to more equitable, more cost-effective services through primary health care, also to improve efficiency, both allocative efficiency, talking about to support and develop much more primary health care with cost-effective services, and also technical efficiency by using much better resources allocated to hospital care, and quality through all organization of entirely the system. I mentioned about the regionalization, which means to concentrate much more high-tech and costing services at the high level, and to decentralize primary health care, making much more accessible for population. So finally, this will have much better impact or influence of the different stakeholders. So the ministry is interested to improve the financial sustainability of the system. Will be much more clarity, service provision, much more clear division between levels. And of course, this could be much easier to implement due to the fact that Moldova is a rather small country and could be very well organized. So respectively, we developed the political analysis by classifying different stakeholders on the position of power and positions. So pro-reforms, it's Minister of Finance, Minister of Health, the leading party who now is ruling the country, and of course mandatory health insurance, because all of them are interested to improve efficiency and to increase the value of money. As a possible opposite, we still have from the president cabinet, because he belonged to another opposition party, and of course some professional association and some group of populations. Thank you.
Thank you very much.
So questions?
Thank you. Thank you for your presentation. I just got interested in knowing why would the president be against the Ministry of Health?
It's a very good question. Thank you. We have no time to discuss about the political environment which exists in Moldova. Unfortunately, we have some kind of political division. So the government and majority of the parliament belong to one party. It's a Democratic Party who is mostly pro-reform, pro-European integration. The president belongs to Socialist Party, who is more conservative. It sounds very strange, Socialist Party and conservative approach, but this creates some specific relationship between the power level of power.
Opposition.
But this doesn't scare us.
Yes.
You said you wanted to centralize the complex services. Does it mean you will shut down hospitals? Or what is behind this?
So in general, this means to optimize the inpatient care. It's not excluded to shut down some hospitals, but this will not be done artificially or only from top down. More, I mentioned about persuasion. And from lesson learned, because such intention was in the past, they failed. Now we learn the lessons and more approaches, more implication of the local authorities, making them to understand better the rationale to have to keep the hospital, which create much bigger burden in terms of financial resources and their responsibilities. So finally, by optimization, by making much more rational distribution of inpatient care, this will allow us also to tackle the problems which you mentioned, to close some inefficient hospitals, and to transfer in terms of scope of work. So the highest level will be mostly acute episode, which are more costly, and at the local level will remain long-term chronic palliative care and something which could be supported by local authorities.
Actually, Moldova has experience with closing the hospitals in late 90s and early 2000.
It's not about closing now.
Of course it's not. It's redesigning. So they closed about 300?
We had 350 or 60 something hospitals in such
3 million
countries, and we dropped until 86.
Yeah. So it's about efficiency and quality. And actually a reaction from population was very positive, because they knew that for a small drive, they're going to get better quality of care. So that was one motivation. Very good. Thank you. Okay, we have
Nigeria.
Ethiopia.
We're last.
Yeah, Nigeria is going to be the last. Okay, thank you for volunteering to be the last. And that's going to be the shortest presentation, correct? Not many problems in Nigeria.
Ethiopia.
Ethiopia.
So for Ethiopia, we have selected reducing maternal mortality in selected pastoral regions of the country. So my presentation will include the background on Ethiopia, the problem statement, the rationale why we selected this problem, and also the problem analysis, the interventions that we have selected, and also the political analysis. So as you can see from this, we have Ethiopia is found in the eastern part of Africa, and we do have around 98 million people, the total population, and 9 regions and 2 city administrations, out of which 4 regions are mostly populated by the pastoral community, which these regions are, which I highlighted in red star. So the problem statement is there is high maternal mortality in Ethiopia, but that maternal mortality is even higher in those pastoral regions, which is above the national average of the country. And also, if we see one of the best interventions to prevent maternal mortality is skilled birth attendance. But if we see also the coverage of skilled birth attendance in these pastoral regions, the coverage is less than 50%. So this is one of the reasons that we have selected. And the rationale for or the justification for selecting this problem is technically because there is high maternal mortality and these regions are relatively hard to reach, and there is a limited accessibility of health services. And ethically, we believe that we should value the disadvantaged and politically sensitive, because these people feel that they are marginalized and there is continuous instability in these regions. So we have done the problem analysis using the problem tree. So according to the maternal days surveillance report, the primary cause of maternal mortality in Ethiopia is hemorrhage, hypertensive disorders in pregnancy, anemia, and obstructed labor. But also we have further analyzed the problem using the 3 delays model as a conceptual framework and the problem tree to analyze the problem further. So we have identified the problems in each delay that contributes to high maternal mortality. So the first delay is delay in decision to seek care. So lack of awareness about risk of home delivery, weak health communication activities in those regions, health education that we are providing are not customized to the community and cultural influence, preference for traditional birth attendants and influence from religious leaders and local chiefs are considered as a problem. And the second one, delay in reaching health facility, geographical inaccessibility, because these areas are mostly pastoral and inaccessibility of roads, shortage of transport, and also inadequate number, but also management of ambulances and affordability that's direct, especially for transport, and also for service fee, and also indirect opportunity costs are considered as a problem. And the delay in receiving care, or the third delay, lack of equipment, especially supplies at primary health care level, and inadequate skill mix of number and skill mix of health professionals, and low motivation of health professionals, and poor referral system also, and inadherence to guidelines and protocols are considered as a problem. So we have identified list of interventions almost in each control now. So the first one, in financing, we propose to roll out the community-based health insurance in these regions, and also for the proposed interventions that we feel that we need additional financing. So one of the proposed intervention is to levy sin tax on cut, and also to conduct allocative efficiency, so that to analyze problems and also the financing mechanisms, and to allocate more resources for the primary health care, and also to increase the budget from the treasury. And in the payment mechanism, we plan to institute performance-based incentives, especially for the community health workers and health center staff, as well as for the ambulance drivers. So we feel that we believe that this incentive mechanism will help for the community health workers to reach out every woman in the catchment area and provide good health education and persuade the mothers to attend antenatal care and delivery in health facility. And in the organization, strengthen the outreach team so that they can provide health education and also outreach antenatal care services and supportive supervision, and strengthen the primary health care, especially in availing supplies and medicines, and also fulfilling the required human resource, also proposed as an intervention, and also improving the referral system by availing the referral guidelines, and to ensure adherence to these referral guidelines through supervision and monitoring. And the other one, as I said in the problem, the local chiefs and religious leaders play a role for the service delivery and utilization. So engaging the religious leaders and local chiefs for health promotion and health education is critical, and also strengthening the women groups and customizing the national health messages to pastoral context are considered as intervention for the persuasion. And we have done also a political analysis, and for the presentation purpose, we have listed only 3 stakeholders that we think are essential: the Prime Minister, the Civil Service Office, and Ministry of Finance. And also we have listed their position in the strategies that we plan to engage them. አመሰግናለሁ። Thank you.
So let me make a couple of comments. Can you go back to the first slide?
The first.
First, more. Yeah, one more. So one thing, back. There. One thing I like about this presentation is it provides a roadmap, structure. Okay, clear structure. I'm going to talk about these 5 points. That's good. I like that. That's my personal clear structure. You have to think about if you're talking to your minister, okay, talking to your boss. You say, I have 7 minutes. here's what I'm going to talk about, this, and this. That's good. Go to your list of intervention. I also like there was a, go back, problem. Back to problem. So, problem statement. Problem statement, there's no statement here, okay? But one thing I like is a clear statement of the problem and ideally a name. I don't think any of the proposals had a name, okay? So here's the name of our program. Maybe it's going to be reducing maternal mortality in Ethiopia by, I'm not clear by doing what, by magic solutions. Whatever it's going to be, you want a name that will summarize what your problem is and what you're doing. Go to what you're doing. This is not to criticize you. This is just illustration. So, how many interventions does he have? How many? On this page. How many more? How many next one? 4 more. Next one. 4 more. Next one. 4 more. Okay, so we said use each control knob, and they've done that. The end result is we have 16 different interventions. So one of the questions is, well, which one is most important? Which one do you do first? How many do you have to do? These are hard questions, okay? And it's also a question of if you're presenting to the minister, what do you really want the minister to do at the end? Right? What's the end? Political analysis. The Minister of Health isn't here.
No, we have structured only I took only the 3.
Only 3?
Yeah.
Okay.
For
Good.
the presentation purpose.
Next one. Conclusion. Is this the name of the program?
No, Sinamaric, it means thank you.
Thank you. Okay, good. Thank you.
No more questions, I think.
Albania?
Good evening, everybody. Thank you very much for this wonderful flagship. We learn so many things from you, and from tomorrow we are missing each other. So let me present our country, Albania. It's a very small country, but in the last year we have done so many things. Our vision is clear: better health and quality, timely, sustainable and affordable access for all the Albanian people. Healthcare is limited resource, but the challenge is bigger for one. Better health status of the population, better quality and effectiveness and provided care, better healthcare value for money. Our pyramid integration of healthcare is based on population. Access for everyone in everything. GAP services, secondary care, regional care, tertiary care, and specialized care. But the vision encompasses many aspects of health, including the reduction of inequalities in health, further infrastructure development, human resources, improvement of safety and quality, equal access for all, integrate preventive services, protection, and promoting health-free. Our levels of care in Albania are from primary health care, based on 421 primary healthcare centers, secondary healthcare, and tertiary healthcare centers. Our priority action area for PHC care is based on health, good information for the people, good prevention for our residents, integration of systems, surveillance and governance, but based everything in research and surveillance system. Target group by diabetes and obesity, hypertension, physical activity, alcohol, and using tobacco. Creating new reconstruction program for our healthcare system based on the consolidation of PHC, starting from strengthening the role of the doctor, increasing quality of health services provided, increasing investment in infrastructure rehabilitation, creating better work conditions for all the medical staff and nursing staff, increasing security, increasing prevention, and equal approach for all. Hospital care in Albania is provided by five tertiary public hospitals, 11 regional hospitals, one for 5,000 residents, and 24 domestic hospitals, which one is provided for 200,000 residents. We are working very well and hard in e-health, creating for the first time in my country. But e-health for us meaning organization, meaning user perception, meaning economy, meaning new technology, meaning ethical, legal, clinical efficiency and efficiency. But we are thinking about new model of financing healthcare, not only in hospitals but also in the primary healthcare system. Primary healthcare is funded under budget and historical budget for many years now. The salary of other staff of health centers, nurses and other auxiliary staff is not related to any activity. Not all indicators are exactly measurable and achievable. Centers' funding is not affected by whether the indicators are implemented. So, for this reason, we need to see and to create new model of financing will include several segments in primary health centers. First of all, settings of metrics distribution of primary health care, separate standard for rural and mountain areas. Second, the definition of a standard primary health care team, doctors, nurse, administrator, based on standard number of patients per PHC team. Enforce the patient's rights to free choice of primary doctor and in other levels. Contracted financing will include a fixed amount for each standard the team, enabling the existence of a team in the public health service network. A variable amount based on capitation, which is dependent on the number of patients. The patient list is to be stratified in age groups dependent on the capitation payment. A variable amount based on capitation, a variable amount to carry out preventive procedures, and a variable amount based on quality indicators and key performance indicators. In hospital healthcare, we are thinking about changing again the financial way, because the hospital care in Albania is financed under budget and historical budget. In contrast with hospital, there are several indicators of activity and quality of services, which are reported periodically by the latter. Not all indicators are exactly measurable and achievable. We are working in very traditional Excel system because the health information system it's missing in our country. Hospitals' funding is not affected by the implementation of indicators. For this reason, we think about, and for new model of financing will include several segments, setting of a matrix distribution of hospital healthcare facilities based on demographic and epidemiologic trends based on the new master plan that we are going to create in cooperation with the World Bank. Contracted finance will include a fixed amount for each hospital on a zero-based budget system, basic overhead, a variable amount based on the provision of a basic benefit package of outpatient diagnostic and treatment procedure, this means fee for services, a variable amount based on the provision of a basic benefit packages of inpatient medical procedure fee for services to continue after that in DRG systems. A variable amount based on the provision of a basic benefit package of strategic procedures known as health services package fee for services, and a variable amount based on the quality indicators and the key performance indicator. So, during these days, we heard about many indicators you use in our country, so we are going to discuss tomorrow some key performance indicators, and we put, first of all, length of stay for a particular procedure, proportion of patients treated through the day hospital in relation to inpatient care, consumption of medicines and medical supplies for each DRG group, efficiency indicators, number of rehospitalization, waiting times and lists for defining procedure. So, How? Creating new action plan to define the transformation of the public insurance fund financing through contribution to continue from a Bismarck model to Beveridge model. Revenue resources, general taxes and out-of-pocket payments by individual citizens. And we have here on conceptual design of framework for national insurance systems, and we created the Bismarck model flow of funds map. New direction for the future for my country, revise accreditation standards, increasing coordination between hospital mergers, community hospitals, management and quality improvement, internal quality improvement, strengthen the governance, integrated delivery system responsibility for all, and the revised payment scheme. So we put 5 priorities in short term and the long term. To the short term, we're thinking about prevention, primary health care, the regional hospital care. In the long term, we have technology, health information system, and redesigning the system of healthcare. So I prepare something for the checkup because it's the only a part of the prevention in my country, but in the end, I want to give the key message. Alone, we can go anywhere. So the success for the integration is to work all together. So I'm very happy to be with you here and to share my country and our success. Thank you.
Interesting. Comments? Questions?
I didn't really understand how you plan to pay in the primary health care if your patient is allowed to pick up a family doctor. So how will you control to which family doctor the money go, where is the patient, if you don't have health information system, like how it is possible?
We have information system, but not integrated information system. We have part of some programs, different program in primary healthcare, different program in health insurance fund, but not interface between them. For the moment, we are creating new, actually, I don't know in English, but it's one government, let's say, agency, and they have working to create one health system for all the Albania. So about your ask, we are from Health Insurance Fund. We have created some contract between insurance fund and the doctor, and we have put some indicators based on the activity of the doctors. And we say this doctor may every day have exactly the number they have to program for the day to give e-prescription to the patient, and every month they are going to give us the information about their activity. But we are still one step behind, so we have to work hard to create new system. But I think the first of all, we have to trust our people. We working with them all together as a team, and to trust. And after that, to ask the patient to trust us.
Okay. Which countries did not present? I know it's Nigeria. Indonesia. Do you want to present now? Indonesia? Go ahead. Indonesia. You volunteered to be the last one.
No problem.
Sorry. Sorry, Bobby. There's the clicker. Yep. Forward, back. He's forward, back. You can use either this one or this one, whichever.
Thank you for the opportunity. Good afternoon, all. I'm representing Indonesia. My name is Okta, and this proposal I want to explain is about e-health towards Indonesia universal health coverage era. As you know, Indonesia have been implemented a national insurance scheme since 2014. This is one part of we try to reform about the e-health that will be supported not only the national insurance scheme but programmatic as overall. This is Indonesian context, as maybe you, one of you have known that Indonesia consists of many islands, and we are biggest 10 up to the fourth, maybe third of the biggest population in the world, 265 millions, and poor people is 25.75 million up to 2018. This is the country which also vulnerable with the natural disaster, and also we are very vulnerable to pandemic disease. And we are consisted of 34 provinces and also 514 municipalities or districts. This is the epidemiologic Indonesia based on the last 10 years. We are shifting from the communicable disease to non-communicable disease that will be translated to the biggest catastrophic cost during the implementation of the national insurance schemes. The national statistic of Indonesia is we are going lower of the infant mortality rate and also maternal mortality rate. And we try to the plateau of the total fertility rate as well. And the life expectancy at birth is relatively slightly higher. In male, it's going 98 and 72 years for the females. Indonesia is since 2000 we implemented decentralizations, and that's representable in the organization chart as here. Ministry of Health is regulators, and the providers is come from the municipality or districts of local governments. The program of Indonesia is part of one of these. It's the National Health Insurance Scheme. The context is we implemented this as a contributory national insurance schemes that all Indonesians mandatory to join this insurance scheme, and it's cover inpatients, outpatient, and also ambulatory for the referral healthcare from the primary to the referral healthcare. This is the recent result from the National Insurance Scheme. We subsidize people who are poor, as this PBI is, for the 2018, almost 92 million Indonesian who poor covered by the Indonesian government and paid by the Ministry of Health. And the health provider of JKN or the National Insurance Scheme is almost 22,000 that have been joined by the scheme and paid by the capitation, while the referral is the payment is based of the DRG, or we call it Indonesian CBGs. How we can improve the national health system? This is have been regulated by an Indonesian government. We try to not only improve the WHC, but we try the proposal. The proposal is how we can improve the health management system by improving the health in information system to make the decision is more performance based, and to make the planning is more evidence based, as that will be resulted more efficient and get an allocative efficiency. What we want to do, the strategy is how to improve the implementation of this data and how to manage the data resource and how to present the data that the stakeholders, not only the Ministry of Health, can make the decision based on the evidence base or the performance base. This is the design of the interoperability of the e-health that we are proposing. So there is the internal operability and also external operability. The internal is covered within the Ministry of Health, while the external is cover a lot of stakeholders involved. One of them is BPJS Kesehatan that is the agency who cover and who run the national health scheme which is applied as a purchaser of this national insurance scheme. And how about the problems or the expectations that we need to cover? One of them is we need to cover the fragmented one into the integrated one. So a lot of system, since the Ministry of Finance tried to encourage MNH through the technology of electronic based applications, a lot of institutions make their own application, resulted into the fragmented system, and we expect this to be integrated through this proposal. How to make it integration? The initiative is to make a data sharing via interoperability and standardizations of the data management improvement and evidence-based policy making to enhance the accountability. And this is run through the One Health data policy. And this is the technical interoperability that translated about the e-health that we are proposing. I think that's all about the reform about Indonesia. I think, thank you very much. Do you have any question or comments?
I have. Actually, Indonesia team was gathered a little bit late because some participants didn't get visa on time. Actually, this year we lost about 37 participants because of visa. 37. So people want to come, but sometimes it's difficult. Maybe we should have next course in Indonesia. Or how about Bali or Abuja? Okay. So they managed to scramble together over the weekend and work hard and try to do the diagnostic tree. It was interesting how they looked at ethical as a moral, economical, and other aspects. But the focus was really on information system to fix underlying causes. They didn't include very much other maybe control knobs, behavior change, regulations, persuasion, right? But we have to give them a big applause for trying. Thank you. Questions? Thank you so much.
Thank you.
And
Last one.
Nigeria. I'm going to watch this carefully. That's forward. That's backward.
Ladies and gentlemen.
Forward. Backward.
You should make a good introduction. Ladies and gentlemen.
Okay, ladies and gentlemen. Actually, this is a presentation on behalf of my country, Nigeria. Truly, what we are presenting today is a true life situation in Nigeria. And it's what's improving maternal health in my country. And what we told the Minister of Health is that out of the 200 million population that we have in the country, we lose approximately 950,000 women and children under 5 every year, which is almost 1 million. Therefore, we call the program Saving 1 Million Lives. The idea is one 747 aircraft crashes with about 500 people is breaking news in CNN. But 1 million people are dying every year in Nigeria is not a breaking news. To us, it's breaking news. And that's what we told the minister. This is breaking news for him. And if he decides to follow this process, he can reverse this the trend. And our focus is that in universal health coverage, women and children are first, actually. Whatever you're going to do, if you're addressing universal health coverage, women and children are first. And with our high mortality rate, maternal mortality rate in the country, our focus on women is actually key. Therefore, looking at financial protection for the women, looking at preventive, promotive, as well as curative, as far as women is concerned. But why this high mortality, paternal mortality in the country? 3 reasons: antenatal and postpartum hemorrhage, sepsis, and of course pre-eclampsia, which is as a result of hypertension. We looked at the basic causes of this high maternal death in the country, starting from the 5 Ds and the 3 Bs. The 3 Bs are the barriers. First barrier is cultural barrier, financial barrier, and infrastructural barrier. And of course the 5 Ds, which is delay in taking decision to go to the facility for antenatal in the first place, delay in taking decision to go for labor, delay in getting to the facility because of poor access, delay in getting blood when the woman is having antepartum hemorrhage, delay in taking decision to seek services in general, and of course, the last delay is delay even within the facility because of poor attitude of healthcare workers, and sometimes lack of the healthcare workers in the facilities. And therefore, putting all this together, we believe are the reasons for the high maternal mortality in the country. Therefore, for us to address this, we have to look at these issues and see how we can improve the situation. And the minister actually agrees to that. And of course, we now decided to set up basic services that will protect these women. And the minister called it, besides saving 1 million lives, also is revitalization of the primary healthcare system. One, looking at the PHC. The basic package was designed for the women: immunization for the women, elimination of mother-to-child transmission of HIV/AIDS, antenatal clinic, antenatal care, including screening, nutrition information, and counseling. And of course, looking at malaria as a major cause of antepartum hemorrhage, also, and other problems related to pregnancy. The IPT is also part of it. Delivery and episiotomy, postnatal services, family planning, very important, and of course, adolescent sexual and reproductive health. And of course, lastly, at the secondary facility, a woman that requires cesarean section will also have access to cesarean section as well as management of complications. Now, in terms of additional funding, we look at areas where funding can be obtained from. The government passed a legislation, the National Health Act, whereby 1% of consolidated revenue will be going to that. We also plan to ring-fence funds from the regular budget, looking at grants from international organizations, and of course, funds from other sources. And in fact, in terms of regulation, government is so strong about it, government is committed. Therefore, the National Health Act was enacted. And of course, the National Health Insurance Scheme Act was also enacted, and in fact, being reviewed in the country at the moment. That shows the high level of commitment, both political commitment as well as commitment of society. But of course, we look at the political situation in the country to see how we can increase support. The National Assembly is key. The civil society, the traditional birth attendants, which really are key, and of course, the healthcare workers also, and then the development partners, who are very important in the country. And lastly, the people. We need the commitment, the persuasion of the people to support the system so that we can actually continue to implement this new reform. In terms of service delivery, specific activities have been identified. Deployment of female midwives as frontline workers, effective referral system, revitalization of 10,000 PHCs across the country to make them functional. The idea behind functionality is that all the services will be available, and of course, also building accommodation for healthcare workers within the facility. And of course, engagement of the traditional birth attendants in some communities, TBAs are still very high, which also accounts for the high mortality, maternal mortality. The non-financial incentive for healthcare workers, we are also bringing that in to support healthcare workers who are working in rural areas. Then training to deal with bad attitude of healthcare workers. And of course, issue of supply system is important, therefore putting emphasis on procurement and supply of drugs and equipment. Male involvement is very important, like we said earlier on. Delay in taking decision to go for antenatal, delay in taking decision to go for labor. The husbands are very important. Therefore, we are designing a program to also engage the males, the husbands, and of course, accurate civil registration and deaths, and stillbirth in the country. Now, these are the things that we're putting together in the program Saving 1 Million Lives. In conclusion, I say thank you very much. Dankeschön to our people from Lebanon. Shukran jaziran. Felamen our German brother Duncan Shan. Merci. And this is our jersey in the World Cup 2018. Thank you very much.
This is marketing strategy, big time.
Exactly.
He wanted to be the last to present. He had outstanding PowerPoint transitions. He included mercy, thank you, falaminderi, pasibo in all kinds of languages that we have. This is... So, when are the elections, Ibrahim?
Elections in Nigeria?
Yeah.
2019, next year.
Next year.
Exactly.
You're ready.
Early.
You're ready. Interesting. And but what is shocking really is to say that if you have a plane crash with 100 people dead in a plane crash, it's on the news. If you have 1 million people dead every year, it's not on the news. This was shocking. This is very powerful statement.
Saving 1 Million Lives program already exists.
It's Hopkins.
How many lives has it saved so far? Two? How many lives has Saving 1 Million Lives program saved so far? What would you do to improve it, to make it work better?
What we need to make it to improve, to make it better, is the fact that performance management assessment, which is very important in terms of auditing of activities within the facilities and of course the states. And also looking further to see how the problem of healthcare workers and management within the facilities will now introduce the performance-based financing.
Ibrahim, do you think it's working well now?
Yes, it is now Saving 1 Million Lives program for results. Now, we have not deployed as against a system where government operates the system from the top. Now, resources have been deployed to the lowest level.
How will you sell it to the next government if it's a different political party?
Very easy. Because the greatest beneficiaries are the states. And there are clearly spelled out disbursement linked indicators, which has nothing to do with the federal government, but with the states. The state governors are the ones that have actually taken ownership of the program. And most importantly, the community, because the healthcare workers and the people are benefiting directly from the program now. As against when Abuja, at the federal level, will just sit down and decide what to do. Now the state decide what to do with the resources.
What is demonstration of state ownership?
Demonstration?
Yes.
Yes.
How do we know that the states are really owning it and implementing it?
Good. Now, with the disbursement linked indicators, clearly we conduct annual surveys that will now, each state is competing with itself. It is no longer some states hiding under some state, because in Nigeria, there's, just like most other countries, there's intra-country variation in terms of performance. Now, with the new program in place, whereby each state actually is competing with itself, data is now being disaggregated according to state level. Therefore, funds are allocated to states or are given to state disbursements based on your improvement from your initial baseline data. Therefore, you are now competing with yourself. They have now taken ownership. They now conduct meetings to review progress from the data on a monthly and quarterly basis.
So one last question.
Yes, please.
Do you have a list of ranking of states according to which one is doing best and which one is doing worst?
In last 2 years ago, when we published the first, one of the indicators is for you. For us, after the survey, we should now publish the data, the ranking of all the states. Incidentally, when it came out around 9 p.m., the Honorable Minister called me and said the governor of his state called him and said his state is the last. Honorable Minister, we sent you to Abuja to protect us. How come you are embarrassing us on the pages of newspaper? And he said, because you did not do well. And what was the reason? His state healthcare workers are constantly on strike. The governor does not pay them salaries. Therefore, they're on strike. The state is doing very badly. There is no way the minister can influence that. Therefore, what the governor should do is to look at data and see how he can improve. And that advertisement will now show that they're doing well subsequently. So it's a shame, game of shame to those who are not performing. And the president shakes hands with the governors who are performing and gives them checks to go and further improve their performance to the state.
Thank you, thank you, thank you. Okay. Now, so number 10 is Nigeria. So here's how the process works. Say again? Okay, so we're going to vote. You have the voting ballots. So you cannot vote for your own country. Okay? One vote for the best. And here's the list. Okay? So while you vote, you also have another task. You have evaluation sheets in front of you to fill in. Please do that. And we'll start in about 10 minutes. One per person, but you cannot vote for your own country.
You have to ask them to put their country name on the back.
Okay, put your country name on the back of the ballot. Okay?
I cancel this.
Then we should submit our votes.
Huh? Yeah. Vote here. And evaluations, please. We have to leave the room by 5 o'clock, so let's hurry up.
Sarah, you are voting? Are you voting?
Sarah.
No?
So you just put this like this.
Maybe it gets both.
And the winner is...
So on the back is their own country. So they vote for Ethiopia. So one is Ethiopia is 7. That's a list of countries. Ethiopia is 7. So, yeah. This is Moldova, right?
No, just watching the photo.
No, look, just faster, it's not the podium.
Hey.
Ricky. Jela. Ok, ovo je Moldova. Ajmo po grupama im davati, da im ne damo po jednom. Jel' tako? So these are participants from Albania, right? No? Yes?
Exactly, no.
No.
It's Kosovo.
Oh, that's Kosovo.
Yes, it's Kosovo.
Violeta, Kosovo.
Kosovo, yes.
This or Kosovo?
You'll be my vice Kosovo.
Okay. Let me find yours.
This is,
Albania.
yes.
Okay, one.
One.
Odnesa me. Mirala. Eva.
Yes. Yes.
Melissa. Everybody, is that it?
Yes,
No.
it's okay. Five, thanks.
Hey. You need a flash drive.
Samo nemoj razmatavi na kraju tog Kosova. A to je Kipit.
Fatima, send email.
We are counting votes.
I'm very in the spirit of today's election. Although I don't think Thank you so much for helping.
Okay, imaš jednu zemlju gotovo.
Ovo je Moldova,
Pravno.
ovo je Kosovo, to se radi na Nigeriji. No, we just go first.
Sarah?
Yeah.
And results are. The winner is Ibrahim Tatissas.
Okay. Okay. I got the votes. Can we vote again? We all won. Okay? Well, there was one team that stood up a little bit. So, Nigeria. So why don't you guys stand up? Anybody wants to comment? Why did you win? How did you win? How did you do this? With support from Kosovo?
Actually, the case of Nigeria was so realistic, and also Ibrahim had so much knowledge about the case, so he knew very depth of the problem. So it seems like if you want to say 1 million people, and also the comparison between what was your comparison between 1 million people in your country and an air crash? So that is also something sentimental, which also was really touching. So I congratulate the winning team.
Okay, we are handing certificates, so why don't we, Kosovo, can you please help take a look? Oh, yes, there will be a gift. And actually, we have a gift. And it's not squeaking. It's actually something that is useful. How many people? 9? 6? 6 Nigeria team, right? So we thought that when you're doing your sector reforms, you should be able, every morning when you wake up, think about our beloved flagship course. Right?
Yes, sir.
And when you have your wonderful coffee, you will think about the World Bank flagship course. So the first thing you see in the morning is Project 1 billion, I'm going to save the lives. World Bank Nadim. Oh, God, I don't want this coffee. All right. Thank you. Usually at the end of the course, and I do hope you liked it, I would like to do a couple of interviews with that little camera just to see if anybody wants to say something, how did you feel about it? Did you like the course? Did you appreciate it? If you didn't like it, what would you improve? So whoever wants to provide 2, 3, 4 minutes feedback to us, it would be really very useful. That is in addition to evaluations that you're doing. And we continue doing this both here in Washington every year, around this time, Michael, right? End of October, beginning of November, trying to find the right time, but also in different countries and different regions. There's a lot of work in front of us to make it better. We would like to create alumni associations so that you keep hearing from us, you keep receiving maybe emails, and we get your feedbacks. That's not easy. That's not easy to be done, but let's think how we can do it maybe together. If there are any ideas, please write them down or send us an email. We can expand it worldwide. And then have one more PowerPoint. Professor Mark, when he was saying his goodbye, he used to have this Irish poem saying goodbye. And what he was saying is, may the road rise to meet you. May the wind be always at your back. May the sunshine warm upon your face, and rains fall soft upon your fields. Until we meet again. Thank you guys so much. This was a wonderful course. So the course is closed.
People have their certificates. Do you want me to say something or not? If you want to, yes, please.
So, one final word. So just think about your journey. We hope that you've enjoyed your time here with us. Okay, you can take your certificates back and your flash drive. And just remember as you confront all those problems back home that we're here to help you. Think about all of the different groups you need to work with and keep us informed about your progress. Okay? So, safe travels.
Sorry to take over the mic again, but I